Hello everyone. Thank you for joining this webinar of the Immune Deficiency Foundation, or IDF. My name is Brian Fitzik, Associate Vice President of Community Services at IDF, and I will be your host today. Our topic is ADA-SCID, a severe combined immune deficiency caused by mutations in a gene that encodes an enzyme called Adenosine Deaminase, or ADA. The enzyme ADA is essential for the metabolic function of a variety of cells, but especially T cells, a critical component of the immune system. Learning that a loved one has ADA-SCID can be overwhelming and confusing. You're probably filled with many questions. What does this diagnosis mean? What happens next? What are my treatment options? IDF has a deep understanding of the challenges and emotions you are facing, and the information in this webinar is designed to help you cope and begin making informed decisions along your journey. This webinar would not be possible without the generous support of our sponsor, Leadiant Biosciences, which researches, develops, and distributes novel therapies for several diseases, including ADA-SCID. Many thanks to Leadiant Biosciences for their legacy of serving people affected by rare diseases. Although rare, ADA-SCID is one of the most serious primary immunodeficiency disorders. Children with ADA-SCID lack immune protection against bacteria, viruses, and fungi that are prone to repeated and persistent infections that would not normally cause illness in a person with normal immune systems. As I mentioned earlier, ADA-SCID is caused by mutations in a gene that encodes the ADA enzyme, which is essential for the metabolic function of T cells, one of the heavy hitters of the immune system. Early detection of ADA-SCID is key to treatment, which makes possible life-saving interventions such as hematopoietic stem cell transplantation, enzyme replacement therapy, or gene therapy. In May 2010, the U.S. Department of Health and Human Services added SCID to the recommended uniform screening for newborns. Because in large part of the IDF-SCID newborn screening campaign, all states have added SCID to their newborn screening panel. With the advent of nationwide newborn screening, more infants are being diagnosed with ADA-SCID than ever. This webinar is designed to answer your questions about this rare diagnosis and to explore the treatment options. To answer our questions, we are joined today by Dr. Donald Kohn, Professor of Microbiology, Immunology, and Molecular Genetics and Pediatrics at UCLA. Dr. Kohn earned his bachelor's and master's degrees from the University of Illinois, Urbana-Champaign, and his medical degree from the University of Wisconsin School of Medicine. He completed a pediatric internship and residency in Wisconsin, followed by a medical staff fellowship in the lymphoid malignancies branch of the National Cancer Institute. Dr. Kohn has dedicated his career to gene therapies for blood disorders, and for over 30 years, he has applied his pioneering work to the treatment of ADA-SCID. Now, without further ado, we welcome Dr. Kohn. Hello, and thank you for being with us today.
Okay, well, thank you, Brian, for giving me this opportunity to talk about ADA-SCID. And so I'm going to present material on adenosine deaminase deficient SCID. This is the outline of what I will cover in the presentation. A little background on SCID, the disease itself, and then some more specific detail about the ADA-SCID, one specific type of SCID. Then I'll talk about sort of the three treatment options that are available for patients with SCID. The first is enzyme replacement therapy, or ERT. The second is allogeneic hematopoietic stem cell transplantation, commonly referred to as bone marrow transplant. And then the last one is autologous hematopoietic stem cell transplant, often referred to as gene therapy. So SCID is the most severe human primary immune deficiency, and patients with SCID have absent function of the T and B cells that are the major part of the immune system. Sometimes natural killer cells work or don't in different types of SCID. And we know now from newborn screening we have a fairly good measure of the frequency, and SCID is, from the studies published so far, about 1 in 58,000 children are born with SCID. So it's considered an orphan disease. It's relatively rare. There's maybe 100 patients with SCID born each year in the U.S. And before we had any treatment, so throughout history until modern medicine, SCID was uniformly fatal in infancy. As I said before, there were treatments developed because the patients would have multiple severe infections, often severe chronic diarrhea and growth failure. Fortunately, nowadays, we almost never see patients like that, at least in the U.S., because of newborn screening and early detection. And we've known for a while that a bone marrow transplant, which I'll describe more fully later, can cure children of SCID. So the first transplant for SCID was done for a baby boy in 1968 who's alive as an adult from that transplant and is well. And what determines sort of the success rate for SCID transplants in part is who is available as a match. So if there's a matched sibling donor, there's more than a 95% chance that the baby will be basically cured of their SCID with the transplant. The problem is most patients don't have a matched sibling donor, and so the other sources of donors for bone marrow, either a matched unrelated donor or a parent who's only a half match, called haploidentical, the results have been lower. I'll show some data later about the outcomes of transplants. I'll make the point now and probably then also that we continue to get better, and so the results that we show, for example, here are results 10, 15, 20 years ago. We think we're doing better now, but the only data that we have are from earlier patients. And so just a little of the biology of SCID. So all of our blood cells come from hematopoietic stem cells, blood-forming stem cells that in us live in bone marrow. And in the bone marrow, these cells divide through a series of sort of intermediate cells to make the blood cells that we have in our circulation. So there's granulocytes, or a type of white cells, as our monocytes, red blood cells that carry oxygen, platelets that stop bleeding. So those are all made in the bone marrow from these stem cells and go out into the bloodstream. But separate from that are the lymphocytes, and these are the T cells, the B cells, and the natural killer cells. And this is the active immune system, and they're sort of made from the same stem cells, but from a different branch. And so when we do a bone marrow transplant or a hematopoietic stem cell, it's really the hematopoietic stem cell that we're transplanting, and it gives rise to all these cells in the patient. And then just one other point to make on this slide is that most of these cells, once they're made in the bone marrow, they go out into the blood and do their job. I've learned early on, T cells are special. Before they can go out and get a job, they have to go to college, and they go to the University of T cells, or this gland in the chest called the thymus. And that's where they grow up, and they learn what they should fight against and what they shouldn't fight against. So that's like going to college, the analogy there. And once these cells are made, they are out on patrol against infection. And so T cells have antiviral activity. They also have regulatory roles in controlling the immune system. B cells become plasma cells that make antibodies, and NK cells also have antiviral activity. And in SCID, we're missing the function of those cells. And in the absence of those functions, then we lose their job, and so we lose the ability to fight viral infections, to regulate the immune system, so there may be autoimmune complications. We don't make antibodies, and so then the result is the clinical disease of SCID with the infections that occur. And so we now know that SCID can be caused by a number of different gene problems. The one that we'll talk about today is ADA-Deficiency, or Adenosine Deaminase SCID, which is one type of SCID that I'll talk about. So this was found as a cause of SCID somewhat serendipitously. In the early 70s, there was a family or a few families with SCID, and they were trying to find which family member were the best donors. They were screening family members to identify a compatible donor. This was before we knew about tissue typing, so we couldn't send it to the lab for HLA typing. So they were looking at different proteins that we knew people had different forms of to see which siblings was most like the patient. And one of those enzymes happened to be adenosine deaminase, or ADA. So this is a gel where it's looking, the black blob is where there's ADA activity. These are some 1 in 5 or 2 healthy controls. Lane 2 is from the patient, and lane 3 and 4 are from the parents. And so what they were surprised to see was the SCID patient didn't have any ADA. And Dr. Eloise Giblet, who's the person who made this observation at the Puget Sound Blood Bank, was wise enough to recognize that this might have been meaningful. In fact, showed that in 3 families that she studied, the children with SCID were lacking ADA, and so that's how this was discovered, really kind of accidentally. And so now just what we understand sort of at the biochemical level, and sorry, this is the only chemistry type slide, we have in our cells a chemical called deoxyadenosine. It's the A's in DNA where we talk about ATGCs. It's also used to make ATP, our energy molecule. Well, every day our cells have to break down some of this because they have excess amount, and the enzyme ADA does that. So enzymes basically change a product, and so it removes this amino group to put an oxygen there, and that's known as deamination. So this is adenosine deamination. That's what that enzyme does. And so if a child is missing both copies of the gene to make ADA and they don't have ADA activity, then large amounts of this starting material build up in their body. And it turns out that lymphocytes have high levels of enzymes that work on another pathway that put a phosphate on this to make these other molecules. And it's thought that very high levels of this molecule, deoxyadenosine triphosphate, or DATP, build up, and those are toxic to lymphocytes. And so in fact, when a child is being diagnosed for ADA, one of the tests that's done is to measure these levels. And when a child with ADA deficiency untreated will have very high levels of those metabolites, that's part of the diagnostic test. And that won't be on the test, don't worry about it. So in fact, this is looking at, from Dr. Buckley, who's one of been the leaders in the SCID field for many years, reported a paper where she had treated 132 SCID patients at that time and just looked at their blood cells when they first were diagnosed. So before any treatment, what did they have? And over here is in normal donors who were her control, how many B cells, T cells, and natural killer cells they had. And so in the different forms of SCID, different populations are missing. And in ADA SCID, all 3 types of lymphocytes, T cells, B cells, and NK cells, are severely deficient. So ADA SCIDs probably present with the lowest amounts of lymphocytes of all these other types of SCID. This is the X-linked form of SCID. That's probably the most common genetic form. And so what we know about how ADA SCID presents clinically, most often it presents typically in infants in the first few months of age if there was not newborn screening, when they start getting infections. And so the classic findings would be pneumonia, diarrhea, maybe from norovirus we might now know, and thrush from yeast or candida growing in the mouth. And patients with ADA SCID prior to treatment had severe pneumonia, interstitial pneumonia, inflammation of the lungs. They would have yeast infections in their mouth or other places, fungal infections, this organism pneumocystis that only occurs in an immune deficient patient, and multiple viruses. And so in fact, these viruses and these other infections were often responsible for death within the first few years of life. And because of these infections and the ongoing diarrhea, there was also failure to thrive. The patients didn't grow well. On examination, they wouldn't have the normal lymphoid tissues. They wouldn't have a thymus seen on X-ray. They wouldn't have lymph nodes. They wouldn't have adenoid tissues, which are just normal places where lymphocytes normally live. And in fact, patients with SCID untreated, live viral infection or live vaccinations could have been fatal. And in fact, when I was a medical student, the first SCID patient I saw came from South America and had this BCG, which is a weakened form of TB, to inoculate against tuberculosis, and had severe infection with that. When there used to be live poliovirus, that could be a problem. Smallpox, any of these viral infections or the vaccines for them could be fatal in untreated SCID patients. And they also have an increased risk of getting cancers, mainly related to Epstein-Barr virus. The monovirus can cause that in some SCID patients. And so what we now know, again, with now 40 years or so of knowing about this entity of ADA-SCID, it causes about 10 to 15% of human SCIDs. That slide I had earlier showed some of the other genetic forms. And so if you do the math on 1 in 58,000, the number of births, there's about 10 children born per year in the US and Canada with ADA-deficient SCID. And as I talked about it, of those different genetic forms, ADA-SCID was the first genetic form where we understood the biochemistry, as I showed you on that slide, and the genetic basis. And it was actually the first one where we had the normal gene isolated and could start thinking about gene therapy that I'll cover later. And so I already made the point that ADA-deficient patients have profound panlymphopenia, meaning they're missing all the types of lymphocytes from these accumulated lymphotoxic adenine metabolites. And then there's these three treatment options that I'll talk about for the rest of the talk: enzyme replacement therapy, ERT, allogeneic stem cell transplant, or autologous stem cell transplant with gene therapy. So first I'll talk about enzyme replacement therapy. And this is historically was developed sort of in the 80s. Mike Hirschfield, who's been the pioneer and the leader in this area for a long time, at Duke University Medical Center, did the first trials with this form of adenosine deaminase that has been the available drug until the present time, where bovine-Adenosine Deaminase enzyme was coupled to this molecule polyethylene glycol that makes the enzyme stable. Normally, if you just gave ADA protein to someone, it would only last for minutes or so. But when conjugated to polyethylene glycol, it lasts for days. And so the initial study was just 6 patients treated in this trial at Duke. And they show that the levels after an intramuscular injection peak about 2 or 3 days later, and the half-life is about 3 to 6 days. So if you give it once or twice a week, you reach sort of a steady state level of the enzyme that circulates and can break down those adenosine metabolites that I showed. And so typically ADA enzyme is given by injections once or twice a week. And that's just shows some of the correction of the biochemistry. And so this is from the original publication from Dr. Hirschfield in 1987, where they first showed that this PEG-ADA can be beneficial. And so this shows weeks after treatment, the level of those bad metabolites that are shown in the open squares come down, and the level of ADA in the blood sort of in steps builds up to a steady state level. And as long as you continue the injections and you hold this level of ADA enzyme, those metabolites stay low and the immune system can develop. And so this was really remarkable, and it saved many lives to the present time. The panel on the right shows over the first 6 months when functional T cells, these tests, PHA, are tests of do you have T cells that work. It shows that it takes a while. Again, as I say, the T cells have to go off to college before they can get up and do their things. So it's really not until 3 or 4 months after starting enzyme that you start to see T cells developing. And really it's not until about almost a half a year later that the T cells are getting into the normal range. And so typically we will caution parents that even though we're starting the enzyme, your child will still have SCID in effect for a while and still needs to be protected from infections. So there have been a couple of papers that have tried to look at all the results on patients with ADA-SCID, and this is probably the key paper. It's now 10 years old, and we actually just published an updated paper looking at some of the same issues. So in this paper from 2009, they accumulated all the known patients who were on ADA and what were the results of being on enzyme. And so of the 98 who had started, only about half of the patients were still on enzyme at the time. In fact, 18% of the patients had died. Most of those occurred shortly after starting enzyme because they already had bad infections. Although there is a slow accumulation of some patients still will get infections on PEG-ADA. And about a third, about 28%, had stopped enzyme to go on to another treatment, either a bone marrow transplant or gene therapy. Or a small fraction, they didn't know where they were, so they were lost to follow-up, as we say. And so that enzyme therapy that was developed in the 80s has been the drug that's been available up until the present time. But because it came from a primary source of cow tissue, it was difficult to get consistent source material, and it was complicated. And so the company that makes it, Sigma Tau, now called Leadiant, has spent the last decade or so developing a new form of it. And so instead of purifying it from bovine tissue, they actually make it in the laboratory, so it's recombinant protein. It makes the same protein, it's just made sort of in the laboratory rather than purified from a biological source. And so they recognize the need for a more stable and reliable supply of it. So it wasn't a problem with the product, it was more manufacturing was very difficult. And so they looked at two modifications to try and, while they were doing that, to improve it. And so they went to a recombinant that's made sort of from the DNA so that there wouldn't be all the other materials from the cow tissue they needed to purify it away from. And they also slightly changed the polyethylene glycol linker to further improve the stability. And so that would be called a recombinant. That's what the little R is for, because it's made from DNA. Recombinant ADA enzyme was based on the same bovine amino acid sequence, so it's the same protein conjugated to PEG, and then they developed and did the preclinical testing. And it eliminates the risk of this. These are terms for mad cow disease. That is a hypothetical risk. It's never been associated with PEG-ADA, but it was always a concern using a biological source. And then they did studies to look at the PK, the pharmacokinetics, how long it lasts in the bloodstream, what's its levels. And then they've just completed a trial in a small number of patients to look at its efficacy and safety. And then they just last month got approved by the FDA to market it. And so my understanding is that the old form will not become available when the most recent batch is done, and that the new recombinant form will be available going forward. And just one more slide that and Leadiant provided me with these slides about their product, and I thank them for that. This is just in the small number of patients that they reported early on. So this is sort of an interim or midway analysis. When they looked at what were the levels of ADA in the blood from the old formulation on the old recommended dose compared to the new recombinant form on the new recommended dose, the levels were at least equivalent. If they look slightly higher. I don't know if it's statistically higher, but it certainly is reassuring that the new formulation at least gives the same level of ADA as the old form did. And so, as I said, going forward, this will be the form that will be available for enzyme therapy. So just one comment about ADA, and this is actually work that I did with at the time, a medical student back in 2005. We followed at the time 9 patients who were only being treated with ADA enzyme therapy. They had not had a transplant. And we looked, just by reviewing their charts, what were their levels of T cells when they were first diagnosed with SCID, what was the highest level we could find they reached, and what were they at the most recent time when we were doing the study. And so at the time we were doing the study, the patients had been on ADA from 4 years was the shortest to 11 years. And so when they were first diagnosed, their T cell levels were very low. This dashed line is sort of the bottom of the normal range. So a normal, I think we took this for 5-year-old children. Normal 5-year-olds have this level or higher. So they started out quite low because of their SCID. But in fact, on enzyme, we never measured a T cell level into the normal range. But these are probably sufficient to prevent infections. But what was concerning was by the time we looked later, these levels had dropped significantly. And so it suggested that as a very long-term therapy, enzyme therapy was not giving normal levels of T cells. So it's still, I think, a life-saving drug, but mostly, as I'll talk about, it's being used most commonly as a way of getting patients in good medical condition to then go to either a transplant or gene therapy. So then to talk about transplants, the next few slides talk about sort of the process of doing hematopoietic stem cell transplant. And what's shown here is a bone marrow transplant. So in this top left panel, there's a patient in the operating room under the drapes, and there are needles sticking into the back of their pelvic bone, extracting bone marrow. And so you can take from a person enough bone marrow from the back of their pelvic bone to transplant a patient. So the bone marrow is collected. It's brought to the laboratory where it may be processed to, for example, remove red blood cells. Typically, the patient is then given some chemotherapy to make space in their marrow, and we'll talk about that, and then the cells are given back. And the easiest part of the transplant is actually getting the transplant, because we don't need to put it right back into the bone marrow. We can just put it into the bloodstream, typically through a central venous catheter, because blood vessels go into the bone marrow, and so the cells will circulate it until they happen to pass through the marrow, where they sort of have address labels and they stick and will start growing. The hard part of the transplant is the medical care afterwards, because the chemotherapy has wiped out their immune system and wiped out their blood forming. It takes about a month or so at least for that to recover. And during that time, the patient is even more susceptible to infection. So you can see the parent and the nurse in this picture are fully protected to try and not transmit their normal germs to the very immune deficient patient. And so this idea of making space is that we think that the bone marrow, if this is the patient's bone marrow, is relatively full of stem cells, and there's very little space to put in new cells. And so if we give the patient bone marrow, in this case the red cells are from a donor or they're their own cells that we've corrected with a gene, without any chemotherapy and no conditioning, there's very little space and very little of the donor cells in graft. If the donor is a matched sibling, that may be enough to help the SCID recover, but in most other settings that isn't enough if you don't give any conditioning. Now when we do transplants for patients with leukemia, we're giving very high doses of chemotherapy, so we call that full myeloablation. We're completely ablating their bone marrow. The compartment becomes relatively empty. So when we give the cells from the donor or their own cells gene corrected, they largely take over and all the cells come from them. Well, for SCID, we don't need complete replacement. We need just stable partial replacement. And so what's developed is using less chemotherapy, and it would be called reduced intensity conditioning. And making some space, we get more engraftment of donor cells. And so most of the gene therapy for SCID kind of use reduced intensity conditioning, and it's enough to increase the engraftment of the patient's own stem cells without giving full dose of chemotherapy. And the same thing with transplants. Our goals are continuously to try and use as little chemotherapy as is necessary, because chemotherapy obviously can have short-term and long-term problems. And so just to make the point that hematopoietic stem cell isn't just for bone marrow anymore, there are now two other clinical sources of stem cells for a transplant. And one is so-called blood stem cells. If a patient is given growth factor that normally makes the white blood cell count go up, so it's sometimes used after chemography, one brand is Neupogen. If you give that for 5 days, it causes stem cells to leave the bone marrow and go into circulation, sort of the opposite of that picture I showed you before. So then instead of doing a bone marrow collection, you can just collect blood from a patient through intravenous lines. It runs through a machine that sort of separates the cells by density. You can collect the white cells to make the stem cell product and give all the blood cells back to the patient. So it's called leukapheresis, or white cell collection. And so mobilized peripheral blood is actually the way most adult stem cell transplants are done nowadays. And finally, the third source is the umbilical cord. And so I'm sure many of you have heard of this, that when a baby is born, they have in their circulation to the placenta and back some of their own blood that has stem cells in it. And so once the cord blood is clamped, you can collect from the placenta about 50 to 100 ml of the patient's own blood, the baby's cord blood, that has stem cells in it. So umbilical cord blood has the same stem cells as bone marrow and can be used for stem cell transplants. And normally this is wasted. Normally the placenta with the stem cell in it is thrown out, but it can be recovered. It requires either a center that's doing that, for offering that for all patients, or active collection through, for example, there are companies that do that. But that is also another source of stem cells. So the first bone marrow transplant for SCID was reported in this paper from the New England Journal of Medicine from 1975. And Robbie Parkman was my mentor in bone marrow transplant. And so the group at Boston Children's had actually already transplanted these 3 SCID patients among several they had transplanted from 2 different families. And after the report came out from Seattle about ADA deficiency as a cause of SCID, they looked, in fact, found that in 2 of the families they had treated, 3 of the patients were ADA-SCID. They now knew that. And in fact, in then studying these families, they could find out that ADA deficiency and SCID were associated and inherited as autosomal recessive, meaning that's a type of inheritance where both parents might be carriers and the child's boys and girls can get it equally. And they reported that they performed a successful bone marrow transplant in 2 of these patients. So they actually did the transplants, at least in one of them, maybe both, before they knew they had ADA-SCID. They knew they had SCID, and they now could report that bone marrow transplant treated that type of SCID. And they found that they had normal immune function was established in both children, but in fact the deficiency of ADA persisted in their red cells, erythrocytes. They didn't give them any chemotherapy, so it was that minimal extra space, enough for the immune system to develop, but not enough to replace the other stem cells making blood cells. And they reported there was establishment of normal humoral, which is antibody, and cellular, which is T-cell transplant in these patients. And in fact, in one of the cases, the donor, the brother or sister, was a carrier, was a heterozygous, and that still was enough to make the patient better. So that was sort of the first case. And then this is a very recent paper, a relatively recent paper, that looks at sort of where are we in the last decade or so. So this was a paper that was published in the journal Blood, where about 5, I think, or 6 centers pooled together their results from 106 patients with SCID who had had transplants sort of in the 90s into the 2000s, I believe, so a while ago to some extent. And this is just looking at survival. And so you can see that this top line were those who had a matched sibling donor. Other those who died shortly afterwards, again, probably because pre-existing severe infections, about 90% of the patients were alive and well, out to many years. But as the level of match decreased, the survival was somewhat lower. So this is matched family donors. If there happened to be a cousin or someone who was a match, that matched unrelated donors, so someone found through the registry who's a close match, mismatched unrelated donors, and parents. So in this retrospective series, transplants from parents were not, well, only about half the patients survived. Those have certainly changed since that time, and I think the results are better now than they were. But this is sort of the biggest published series of only ADA-SCID patients' transplants. And one of the limitations of transplants from one person to another is the immune reactivity. So when we take bone marrow from a patient, we're also getting some of their blood T cells, and in the new patient, they can look at them as if it's a foreign graft and react against it. So that's the graft versus the host, or graft versus host disease. And that still remains a major problem. Even with a matched donor, it can be a problem in 5 to 10% of patients. And as you move away to less well-matched donors, like the unrelated donors, GVHD becomes a bigger risk, and that's why the outcomes are probably lower. And so that then sets the stage for gene therapy. And so the hypothesis is that gene therapy using autologous, or the patient's own stem cells that are corrected with the normal gene, will have the same beneficial effects on blood cell production or function without those immune complications of transplant from one person to another or other person's stem cells. And so the hope is that by using the patient's own cells, we won't have graft versus host disease. And so, in fact, so this should absolutely eliminate risks of graft versus host disease, and also the need for immune suppression given before and after the transplant, which we typically do. We still, however, need to make some space to get those stem cells that we put back have a landing place in the patient's bone marrow. Oops. Sorry. And so the idea is, this is again another version of blood cell formation from the stem cells. What we need to do then is take the patient's bone marrow and in their stem cells get in a normal gene. And we now actually have 2 ways to do that. Sort of the standard way that I'll talk about today is adding a normal copy of an ADA gene in a virus. Sort of a new approach that's developing is to edit or actually fix the broken gene in the stem cell, and that's with a technology that you may have heard of called CRISPR, but that's not in the clinic yet for ADA-SCID. And so the process then of gene therapy is the patient is their own donor. And so we'll do a bone marrow collection from the patient, take their bone marrow to the laboratory. We have GMP, good manufacturing practice, or clean rooms. We isolate the stem cells, we add the gene, then we prepare the cells to give to the patient. That may either be fresh or frozen. During that time or before the transplant, the patient will then get some chemotherapy to make space and get their own cells back. And then we can follow them afterwards to see, is it safe? Did the stem cells engraft? Are the white cells functioning? And have we eradicated basically the SCID disease? And so the technology uses viruses to carry the genes. So this top map is sort of a diagram of the genes of a virus, a type of virus called a retrovirus. And what we can do in the laboratory using recombinant DNA is remove the virus genes and clone in like a normal human ADA gene. And then the ends of the virus can get that gene into the cells where it can then act like another gene and make messenger RNA for that and make ADA protein. So we're basically adding to the patient's cells a normal ADA gene. And that's shown here. So here's the virus with the normal ADA gene in it. It can infect into the hematopoietic stem cells, and then its genetic material is copied into DNA, which goes into the chromosome of the cell. So this is a stem cell. This stem cell will have been permanently modified to now have an extra normal copy of ADA that can then make its messenger RNA and make ADA protein. So not only does this stem cell have that gene, but then the billions of blood cells that it makes will inherit that gene from it because it's part of its chromosomes. And that's the technology that allows us to add genes permanently to stem cells. And so that's just shown. So in the laboratory, we culture the patient's stem cells with the virus carrying the gene, plus some growth factors that make the cells happy and active to take up the gene. And we do it in clean rooms. This is my lab group who work in our clean room, so it's all processed in a very ultra-clean environment so that the cells don't get contaminated for the 3 or 4 days that they're in the laboratory. And so in fact, gene therapy has developed really over a couple of decades, and this is just sort of a timeline showing the original description of ADA deficiency as a cause of human SCID in 1972. In the mid-80s, we isolated normal human ADA genes in the early 80s, and then the mid-80s started making the first viruses to carry that gene, and that then led to the first trial of gene therapy for ADA that was done at the National Institutes of Health by Mike Blaise and French Anderson and Ken Culver, where they targeted T cells from patients. But shortly after that, most of the trials then moved to targeting stem cells, and those were trials done in Italy, in the UK, and in the US. And in fact, that then led to the first approved gene therapy in Europe, which was an ADA gene therapy that's marketed in Europe called Strimvelis, and that's available for patients to get now. During that time, we actually started developing a new type of virus to be used for ADA gene therapy called a lentiviral vector, and we've been working on that and using that in trials for the last few years in the US and the UK, and a company that I'm associated with is now working to get that approved as a treatment in the US and in Europe. This slide just shows what gene therapy looks like. So this was a patient who was treated now 7 years ago. She had an older brother, so she was picked up at birth, started on Enzyme right away, and then at 3 months of age had gene therapy. These are just some of her numbers. So she got 6 million stem cells per kilo, which is a good dose. The vector copy in those stem cells was good. She got a good level of the chemotherapy. We measured the level of the area under the curve, and it shows her immune reconstitution. So she came in on Enzyme, so had some cells when she came in, unlike when she was born. We stopped her enzyme at the time of gene therapy. Then over the course of about 3 to 6 months, everything came up. Her absolute lymphocyte count, that's all the lymphocytes, her T cells, her CD4, CD8s, D cells. And so by 2 years out, she had essentially normal levels of all these cells. She was able to stop immunoglobulin replacement. She was able to stop antibiotics and has been a healthy, normal child since that time. So then I just want to close with showing some data. There's an organization in the US and Canada called the Primary Immune Deficiency Treatment Consortium that's a group of 44 centers throughout those countries that take care of the majority of the patients with SCID and other severe immune deficiencies. And the job of the PIDTC is to study what's been done and to come up with new treatments. And so I'm involved with an effort within that group to look at all the ADA-SCID patients that were treated at these centers. And so we're working towards a paper, but we presented an early analysis at the Clinical Immunology Society meeting this past year, where 118 patients with ADA-SCID in the US and Canada were registered, and data on them was entered into this with parent consent. And so we reported 118 patients from 26 centers treated over a long period of time who were diagnosed with ADA-SCID by way of very specific criteria. And in this little analysis, we compared just the outcomes of the patients in the earlier era, 1977 was our earliest patient, to 2000, versus more recent patients, just to see how results have changed. And this is a survival curve, and I said earlier that we think as transplanters we're always getting better. So this shows that in fact back in the in that earlier period there was only about a 70% survival for patients with ADA-SCID, whereas in the more recent 15 years it was up around 90%. And in fact we think it continues to get better as we have newborn screening to find patients before they get sick, as we have safer transplants, if we have gene therapy. And then the last data slide that I'll show you just looks at, again, from this same analysis, we looked at how were patients treated. And so patients were either initially treated with the hematopoietic stem cell transplant, and if that didn't work, they maybe went on to get other therapies, or they first got enzyme onto another therapy, or they got gene therapy. And so the blue bars is the earlier era. And so in the earlier era, the most common way patients were treated was with a stem cell transplant, although it's probably second most common is they got enzyme and then a stem cell transplant. The red bars are the more recent era, and you can see that more recently, in fact, the most common treatment was to get enzyme therapy for a while and then have gene therapy. And so how we're treating patients has changed over time, and gene therapy is becoming more of a common way to treat patients. So this is my last slide. And so I mentioned that from that blood paper from 2009, a group of the investigators who were involved in the original report listed here, plus I've joined the group since that time. I had a meeting in Toronto this summer and discussed and presented all the data for these different treatments and came up with our recommendation of how we propose ADA-SCID should be treated. And so what we're saying is if a patient is diagnosed with ADA-SCID, at that point we think they should be started on enzyme therapy. Because we want to lower those levels of metabolite to allow their immune system to start recovering. And so we would recommend they would be started on enzyme therapy as soon as possible without the diagnosis, as soon as possible when the diagnosis is made. And during that time, they should then be typed, and siblings should be typed to see if there's an available donor. And then once that's determined, they can then go to a definitive therapy that would be ideally curative. And what's changing in our recommendation with the improved outcome with gene therapy, we think at that point a decision between either a matched sibling donor or gene therapy is probably equally viable, and it's sort of a decision of the physician and the family of which way to go. Gene therapy, other than Strimvelis, which is in Europe, is not widely available currently. It's still research and moving towards treatment, so it may not be available. So if it's not available, an option is then to continue enzyme and have another type of transplant. And the same thing, if there is not a matched sibling donor available, then the other options are either an unrelated donor or a haploidentical transplant, or to continue enzyme therapy. So I think what's new in the new treatments is sort of saying that a sibling transplant or gene therapy, if available, could be considered as equally viable options for the patient. And then I'll close with this. So this is the group of investigators I talked about: Gino Rangelo, Jennifer Puck, Mike Hirschfield, Bobby Gaspar, Ayala Grunbaum, myself, and Alessandro Aiuti. These are sort of the people that have done a lot of work on ADA-SCID over the past several years. And I will stop there and take a breath. Thank you.
Thank you, Dr. Kohn, so much for taking the time from your busy schedule. We really appreciate you joining us today and sharing some great insight and information. We hope this webinar has helped our listeners to better understand the journey so that you can make appropriate decisions for your family. And many thanks to our listeners for being with us. We hope you learned much from this presentation. At IDF, we understand the journey you are on. For many people with PI and their families, the diagnosis can be intensely emotional. For more information about coping with a SCID diagnosis, please visit primaryimmune.org or call 800-296-4433. IDF has a variety of resources on ADA-SCID, from reliable information to emotional support to help you along your journey. Remember, you're never alone. There are always people out there who want to help. We all just have to find each other.